Thank you, Charmin. It's a pleasure to be here this morning and a pleasure to see familiar faces. All of those who have trusted your pituitary health to me, I am very privileged to be part of your journey in this process, and I hope today's presentation will provide some additional information to you. I will leave lots of room for questions at the end so that your important questions can all be answered to the best of my knowledge. And again, thank you for coming. Disclosures, I am on the Speakers Bureau for two pharmaceutical companies, Corcept Pharmaceutical Company and Pfizer. I'm on the Speakers Bureaus for both of those. Anatomy of the pituitary gland is important because lots of the conditions that affect the pituitary, and we're not just talking about pituitary tumors, can press upon adjacent structures and cause problems with nerves and blood vessels. So it is important to remember that the pituitary gland, just to remind you, again, I'm sorry if some of you know all of this stuff, is comprised of two lobes, the anterior lobe and the posterior lobe. It's connected by a stalk or an infundibulum to the hypothalamus, and this is all situated at the base of the brain. The anterior lobe during development comes from the foregut and travels upward, and the posterior lobe is actually, during embryogenesis, comes from the brain and invaginates downward. And that I make that point because the posterior pituitary, which is the part of the pituitary gland that regulates antidiuretic hormone, is actually a collection of nerve endings. And antidiuretic hormone, which is one of the pituitary, important pituitary hormones, actually is not made by the pituitary, but made by the hypothalamus and comes down this infundibular stalk or this connection, and it is then stored in the posterior pituitary before it's released. So that is important to know a little bit about the anatomy of the gland. The gland is really small, about 600 milligrams. It is located in an area which we call the sella turcica. That's Latin for the saddle. And these are important structures that I'll show you better on this next slide that run right next to the pituitary gland. So the pituitary gland is right here. Right above it is the optic chiasm, which is the crisscrossing of visual nerves. And on each side of the pituitary gland, this blue area is the cavernous sinus. It's a collection of veins. And within that cavernous sinus are these important cranial nerves that control vision, as well as the internal carotid artery, which is this red structure that feeds the brain with blood. And right below the pituitary gland is the sinus. This is generally, in healthy people, full of air, and it is through that approach that the surgeon gets to the pituitary gland to remove a tumor or other problem. This is another picture now looking from the side. Again, you can appreciate the pituitary gland, the Turkish saddle here, and the sphenoid sinus, and again, the nose. And going through the nose provides direct access into this airspace cavity and then up to the pituitary gland. Now, the pituitary gland is compartmentalized to make different hormones. And these hormones I've listed here, you know all about these hormones. One of these hormones, which we know as ACTH, is actually made as a much bigger hormone called pro-opiomelanocortin, which is then chopped up into smaller hormones, one of which is ACTH. And the importance of this is that the other parts of POMC are something called melanocyte-stimulating hormone, which is the hormone that causes pigmentation of our skin. And therefore, in situations where the pituitary cells that make ACTH or corticotropes, if they're making lots of ACTH, then perhaps they may also be making lots of MSH, and this can lead to tanning of the skin or a darkening of the skin or hyperpigmentation. And we talked about the posterior pituitary, that it makes antidiuretic hormone, which is actually not true. It actually just stores antidiuretic hormone. And oxytocin, which is involved in the expulsion of milk from the breast during breastfeeding, as well as contraction of the uterus during labor. Again, these two are made in the hypothalamus and stored in the pituitary gland. People who have pituitary tumors are less likely to have problems with these posterior pituitary hormones because, again, these are made in the hypothalamus. Whereas people who have hypothalamic tumors, things like craniopharyngiomas or other large tumors that go up to the hypothalamus, can develop problems with antidiuretic hormone. So for every hormone in the pituitary gland, there's a corresponding releasing hormone in the hypothalamus. And for example, if we take thyrotropic releasing hormone, that results in the release of TSH from the pituitary gland, which then stimulates the release of thyroid hormone from the thyroid gland. So what you can see is that these hormones have multiple levels of regulation. At the very top of the regulatory pathway is the hypothalamus, and the pituitary then is signaled by the hypothalamus, and then the pituitary hormones then act on each of the other glands in the body. And so why is this important? Well, because a lesion or an abnormality at the level of the hypothalamus or the pituitary gland could potentially wipe out multiple hormones. So for example, there are people who may just have a thyroid problem. For example, they had their thyroid glands removed or they have an autoimmune thyroid problem, and so the actual site of a problem is the thyroid itself, and they usually will not have other hormonal problems because they just have a thyroid problem. But if there's a pituitary problem or a hypothalamic problem, multiple hormones can be altered or affected at once. The other important thing to note from this slide, and the reason why this line is yellow, not white like the other ones, is that prolactin actually has an inhibitory signal from the hypothalamus. So whereas all of these other signals stimulate the pituitary cells, dopamine coming from the hypothalamus constantly has an inhibitory or a negative effect on the release of prolactin. Therefore, a lesion or a process that disrupts this pathway will stop an inhibitory signal and therefore will lead to a rise in the prolactin level. Is everybody clear on that? So it's sort of like a double negative. If you stop an inhibitory signal, then you get a stimulatory signal. So any process that affects the pituitary, if it's large enough and interrupts this dopamine pathway, will lead to a rise in prolactin levels. And this is why there are some people who have pituitary problems who do not have prolactinomas, but other pituitary problems, yet still their prolactin level can be high. So not every patient who has an elevated prolactin level necessarily has a prolactin secreting tumor, because if this dopamine pathway is interrupted by any process, prolactin could potentially go up. Now, prolactin goes up much higher in prolactin secreting tumors and does not go up as high in people who have just a problem with the interruption of that pathway. Just don't look at this slide and look at me. It's a busy slide. The importance of this slide is that all of these hormones are talking to each other and interacting with each other, and they have lots of inhibitory, stimulatory pathways, and they work in conjunction with each other. So that it's not just as simple as saying that, for example, growth hormone releasing hormone makes you make growth hormone, but there are other factors that can also regulate growth hormone. So this leads to one of the fundamental themes in endocrinology, which is that one hormone can be regulated by many other signals. This is an important process, and one hormone can regulate many different physiological processes. So if we just think about growth hormone, the name sounds like it's a hormone that results in growth, which it does, but it has a multitude of other effects on the body, such as body composition, brain, quality of life, bone density, muscle mass. And so each hormone has multiple actions, and each hormone is regulated by multiple signals. So very complex. The more I read about pituitary hormones and regulation, the more I realize how daunting it is and how confusing it can be and how little we actually know. Now, what kinds of things cause pituitary problems? Well, most of you know that pituitary tumors cause problems, but it's important to remember that there's lots of other things that can affect the pituitary function. So the majority of pituitary problems end up being tumors, but there's lots of other processes that can affect the pituitary gland. And I think in general you can break it down into processes that are inflammatory, processes that are infectious, processes that are immunological, and processes that are genetic. And you can make this list that I just made for pretty much any glandular problem. So for example, if you take the thyroid can be affected by a tumor. We call those nodules. The thyroid gland can be affected by an infectious process. We can call that thyroiditis. The thyroid can be affected by genetic problems where the thyroid gland doesn't develop. It can be also affected by problems with the blood circulation to the gland. And so for every gland, although it seems like there could be an infinite number of diseases, at the end of the day, you can break it down into these items. So a tumor, cystic problems, problems with blood supply, problems with the immune system. It's interesting that the glands in the body are very susceptible to autoimmune attack. This is another theme, a recurrent theme in endocrinology, is that glandular structures are prone to tumor formation and autoimmunity. Now, fortunately, both of these are benign, but as I'm sure many of you will agree, that doesn't mean that they're necessarily benign in how you feel. They're benign in that they're not cancerous, but they're not benign in how it makes a patient feel and how it affects quality of life. Of course, injury can affect the pituitary gland. Head injury, which is something that I've been researching with Dr. Kelly for the last 10 to 15 years, can cause pituitary damage. And we'll talk a little bit about that later. When an endocrinologist sees a patient with a pituitary problem, there are three questions that are going through our minds as we're evaluating that patient. The first question is a hormone made in excess? Normally, hormones have to be made in a very narrow range. If there's too much, that causes problems, and if there's too little, it causes problems. So the first question is a hormone overproduced or not? And so we have a series of tests that we do to rule out or rule in whether there's hypersecretion or overproduction of a particular hormone. While we're doing that concurrently, we want to make sure that the rest of the pituitary gland is not impacted negatively by that other process and has reduced pituitary function. So at the same time as we're looking for, is there a hormone made in excess, for example, in Cushing's, where it's ACTH, or prolactinomas, where it's prolactin, or acromegaly, where it's growth hormone, you want to simultaneously determine, well, did that tumor also cause a reduction in some other pituitary hormone? And we call that hypopituitarism, an underactivity of the pituitary gland. And the third is to determine whether there is mass effect, whether there's pressure on those vital, important structures that I showed you in the first few slides, like the visual nerves and the internal carotid artery. The best tool that we have to look for mass effect is an MRI. Remember, MRI became available in the 1980s, and before that, we only had CT scans, and the CT scan has relatively poor resolution to look at the MRI. In fact, even a brain MRI sometimes does not have enough resolution to pick up a small pituitary tumor. And so we have to do dedicated MRIs of the pituitary gland, not just of the whole brain. Tumors that are small, like this little dark area, This is a microadenoma because it measures less than 1 centimeter. For those of you who have a hard time seeing it, the pituitary tumor, the pituitary gland is this entire round structure, and here the relatively darker area is the pituitary tumor, and the brighter area is the normal gland. This is the stalk, or the connection to the hypothalamus. This is the stalk where antidiuretic hormone comes down and goes to the posterior lobe, and it sits there until it's released into the blood supply. This is a picture of a macroadenoma, a tumor that is larger, greater than 1 centimeter. It's this dark area, and actually the normal pituitary gland is this thin rim of brighter tissue that's sort of plastered up against the optic chiasm, which is this horizontal line. In this photograph, the optic chiasm is that structure, and here on a different view of the brain, it's this structure over there. The normal gland is that thin rim of bright tissue, and this is the pituitary tumor, relatively darker compared to the normal gland, and these are the internal carotid arteries. And below here, we're getting into the sphenoid sinus and the nose, and this dark area is sphenoid sinus, which is just air, and that's why it's black. For people who have larger pituitary tumors, we do a visual field test. An ophthalmologist does that, and this is a map of areas in the brain that you cannot see. And so in this particular patient, there is a visual field defect in the outer left quadrant, left eye, and the outer quadrant of the right eye. And this is a typical visual field loss in people with pituitary tumors, because if the tumor is pressing on the optic chiasm, which is just above the pituitary gland, you will get this kind of a, what we call a bitemporal visual field loss. So you can't see out in the periphery, left and right. Of course, this and this are areas where we can't see, and this is the normal blind spot. So this is not pathological, this is not a disease. All of us have this normal blind spot where we can't see, and what gets us into accidents sometimes. And then this is the abnormality in this person who has a pituitary tumor. After this person was treated with for the pituitary tumor, you can see that the visual field is improving in the lower panel over here, and some of the dark areas have become lighter, both in the left and the right. So a visual field test is important in assessing for that mass effect. Pituitary tumors can make a hormone like we discussed, so prolactinomas make prolactin. In acromegaly, there's too much growth hormone. In Cushing's disease, there's too much ACTH and cortisol, TSH tumors, and then tumors that make gonadotropins, which are the hormones that regulate testosterone and estrogen. And these are the percentages of each category. In the tumors that don't secrete a hormone, we call them non-functional tumors, because they don't release a hormone in excess. And actually, so the most common tumors would be prolactinomas and non-functional tumors. The next most common would be acromegaly. The next most common would be Cushing's disease. And then the least common would be TSH secreting tumors. These are the symptoms of a person who has a prolactinoma. Essentially, when prolactin level goes down, the reproductive axis shuts down. So if you think about at what time in a person's life is prolactin normally elevated, well, that's normally elevated right after pregnancy, and that's a physiological increase in prolactin, and at that time there is breast milk discharge and breastfeeding, and as long as the prolactin is high, that woman will not have menstrual cycles usually, and will therefore not be fertile during the time that she is nursing. So the symptoms of a prolactinoma would be having those symptoms even when you're not after pregnancy, that it could happen even in men when there's too much prolactin around. Bone loss happens because if you lose the reproductive hormones due to a high prolactin level, you lose the benefits of estrogen in women and testosterone in men in terms of bone protection. And a common theme that you'll see in every type of pituitary tumor is that mood changes and depression will happen. So anytime a person has a pituitary problem, there's always the high probability that it will affect mood and quality of life, regardless of what type of tumor it may be. I put this slide on to just draw your attention to the different presentations that prolactin tumors can cause in women and in men. In a woman who begins to lactate and has an interruption in their menstrual cycles, that usually leads them to see a physician. And if the physician does an evaluation and checks a prolactin level, this woman will then get diagnosed with a prolactinoma. Of course, men don't generally have periods. They may have mood changes that seem to be hormonal, but men don't have a monthly menstrual cycle. So usually in a man, a prolactinoma is diagnosed much later. And at this time, this man is asked to look straight ahead, and as you can see, one eye is deviated to the right, and this is because he has a large prolactinoma that is putting pressure on those visual nerves that are in the cavernous sinus right next to the pituitary gland and caused a paralysis or a partial paralysis of the third cranial nerve, the nerve that controls the movements of the eye. So in men, the presentation of the prolactinoma is usually later and these tumors are larger, and in women, oftentimes we can catch them earlier because there's more signs, for example, abnormalities in menstrual cycle. Of course, in a man who describes sexual problems and sexual dysfunction, the prolactin levels should always be tested before they're given, for example, Viagra or Cialis. We do need to do a hormonal evaluation in men to make sure that there's not a hormonal problem, and only after you've documented that and you rule that out, you can start to treat them. Well, how do we treat prolactinomas? Well, there's two medical treatments that tend to be extremely effective for prolactinomas. These are things that raise dopamine levels. As I showed you in the introductory slides, dopamine has a chronic inhibitory effect on the release of prolactin. So if you can give medications that have dopamine-like properties, like bromocriptine or cabergoline, you can both bring the prolactin level down and shrink the tumor. And these could be very effective, especially with cabergoline, where the effectiveness in normalizing the prolactin level can be over 80%. They do have side effects, as are listed here, with nausea and vomiting and changes in blood pressure, which we call orthostatic hypotension, which means that the blood pressure can drop if you get up too quickly or change posture too rapidly. For the most part, these medications are well tolerated. This is a person who had a very large tumor, and it's coming down into the sphenoid sinus. As you see, this area should have all been black like here, and the tumor has invaded downward into the sinus. These are the carotid arteries, and the rest of it is a big tumor. And after treatment with bromocriptine or cabergoline, whichever one, you see that the tumor is already beginning to shrink. Still present, and over time it will shrink further and further, and it could get to the point where you can't actually see that. The other treatment for prolactinomas could be surgery. Normally, because we have an effective medication for prolactinomas, we offer medical therapy and reserve surgery for people whose tumors don't respond to medications, or people who don't want to take a medication long term. Although this tumor is shrinking on the medical therapy, the data suggests that if the medication, cabergoline or bromocriptine, is stopped, after a number of years, the tumor will gradually come back again. So in a person who perhaps does not want to be on a medication for the rest of their lives, surgery, if the tumor is small enough and can be entirely resected, could be a good option for prolactinomas. Now, this part of the presentation was going to be done by Dr. Katznelson regarding acromegaly, and I'm going to go ahead and just blend it in here as the next type of pituitary tumor. These are tumors that cause acromegaly. We talked about how common they are, and the majority of people who have too much growth hormone, the problem is in the pituitary gland. There's a pituitary tumor. In rare cases, there are other places in the body that growth hormone can be made, and these are called ectopic sources. Ectopic source means that the hormone is being released by an area that it is normally not supposed to be released from. So growth hormone usually comes from the pituitary gland, but in certain types of tumors and cancers, the growth, those cancer cells can make extra signal for growth hormone. These are the symptoms of acromegaly. The problems that shorten lifespan in acromegaly are these. So people have acromegaly, can get hypertension, diabetes, can get pretty bad arthritis, sleep apnea, carpal tunnel syndrome. They can get polyps in the colon, some of which can become cancerous potentially if they're not caught in time. And then they get a whole bunch of symptoms that are very much due to the excess levels of growth hormone. Like, for example, being too sweaty, having enlargement in their body appendages, like their hands and feet, and tongues, and so on and so forth. I'll show you some pictures. This is a patient who has acromegaly, and you can see the hands are much larger. The term acromegaly actually stands for, megaly means enlargement, acro means extremities, so the extremities get bigger. The lower jaw can protrude. We call this prognathism, and usually if there's an astute dentist or oral surgeon, sometimes they can diagnose acromegaly by just checking their teeth, and the spaces between the teeth become widened as the jaw is growing outward and forward. They can get malocclusion of the teeth, they're not aligned. And so again, if the dentist or the oral surgeon is attuned to systemic conditions, sometimes they can figure this out. This is a woman with acromegaly. These are sort of the widening of the spaces between the teeth, and you can see that the upper teeth and the lower teeth are not aligned. So the lower jaw is protruding outward, the mouth is enlarged. This is the underarms of somebody who has acromegaly, and this velvety, darkish brown appearance is called acanthosis nigricans. This is a sign of high levels of insulin or diabetes, and we see this because acromegalics are much more likely to get diabetes. So this sort of darkening of the skin is a telltale sign that diabetes is either present or on its way. And then these are skin tags. Remember, growth hormone is made in excess, so things like to grow. And a person who's making skin tags, they can get a lot of these skin tags. And in the colon, they could be polyps, for example. This is a man who has acromegaly and had a very large tongue, and it was actually obstructing his airways, and ultimately he needed to have a tracheotomy or a opening placed in his windpipe so that he could bypass this obstruction through the back of his throat and be able to breathe. So acromegaly could be quite devastating if it's not caught on time, and can cause a lot of problems with regard to the cardiovascular system and the respiratory system. These changes are often very gradual. So if you look at the photos of this woman who has acromegaly over the span of a decade, you'll see that some of these changes that I described to you is happening subtly over time. And so if you just look at her in 1988, you may think that, well, maybe there's really not much going on, and this is just her appearance. But if you look at the chronology of the photos, you can then begin to appreciate that there's these changes happening in terms of the mouth and the nose, and perhaps if you had a side view, the protrusion of the jaw. So I often ask patients who come to see me to bring old photographs so we can take a look, because we don't know, a person may look reasonably normal, but that may not be normal given how they used to look. This is a picture of identical twins. One brother, so identical twins, share the same genetic structure, so they're identical, but this brother developed a growth hormone producing tumor in his life. Actually, it happened before he went through full pubertal development, so he actually grew, and you can see that the differences that happen in somebody who has too much growth hormone over a period of time. People have acromegaly that's not treated. In addition to having those changes in the body, as I mentioned, they are at a higher risk for mortality or death. And this is due to cardiovascular problems and heart disease. Now remember that sometimes things growing like a polyp or a skin tag may not be a big deal. But for example, if under the influence of growth hormone, the heart muscle begins to grow and becomes thickened, then it will not work very well as a pump. When that happens to the heart's pumping capabilities are affected. It can't really do a good job at circulating blood, and so this is why all these cardiovascular problems can develop. And again, there may be a higher risk of cancer because under the influence of growth hormone, tumors can grow. And many of them are either pre-diabetic or diabetic. Do you guys remember Andre the Giant? So Andre the Giant was a wrestler, and he actually was diagnosed with acromegaly, and he was told by his physicians that he had acromegaly, but he declined to be treated. And the reasons, I'm not sure, but the internet suggests that the reasons were that he did not want, his appearance to be changed. He actually felt that this appearance was important for his wrestling career and his persona. He declined to have treatment for acromegaly, and he died in his 40s from the cardiovascular complications of this disease. So this is a serious condition that requires treatment. Now, how do we diagnose it? Well, growth hormone is made in excess in this condition. The problem with measuring growth hormone is that it's very pulsatile. It's released in bursts, and if you don't measure it 20 or 30 times during the day, you may miss an elevation in growth hormone. The same thing goes with cortisol. Cortisol is another hormone that's made in little pulses, and so a normal person can have a low number for 1 minute and a higher number the next minute. So we can't really use growth hormone. We measure something else called IGF-1, which is actually made in the liver under the influence of growth hormone. So in situations where growth hormone is high, you would expect IGF-1 to be high. And because IGF-1 does not fluctuate so much up and down, that's going to be a better measure. We can measure growth hormone, but only if you do some form of a dynamic test, which means that in this case, you give glucose to the patient to drink, and then you measure growth hormone levels afterwards. And if the growth hormone level doesn't go down after that person ingests glucose, then that means they have too much growth hormone in their body. So again, the important thing with acromegaly and also with Cushing's, which we're going to talk about as the next series of slides, is that you can't just measure growth hormone or cortisol randomly. It's not going to be very accurate. These are the three treatments for acromegaly: surgery, medications, and radiation. If a person has acromegaly due to a small tumor, these are different surgeons in the United States, and then Shimon is in Israel. So their cure rates for people who have acromegaly, who have small tumors on this column, and who have large tumors greater than 1 centimeter on this column. And so the take-home message is that if you have acromegaly from a small tumor, a microadenoma, surgery can be very successful. On the order of 80 to 90% of the time, surgery can put that patient into a cure or a remission. However, if acromegaly is due to a large pituitary tumor, a tumor that is greater than 1 centimeter, then it's no better than 50-50. So although the data is good for small tumors, it's not so good for larger tumors. And unfortunately, the majority of patients with acromegaly have large tumors. This is in contrast to Cushing's disease, where the tumors are almost always very tiny. So acromegalics usually are diagnosed later because those changes in their body appearance is subtle and over a number of years. And so they generally become macroadenomas, and macroadenomas are not going to be cured about 50% of the time. So we need medical therapies, and we're going to talk about some of these medical therapies. One is just to give a dopamine agonist like we did for prolactinomas, but the effectiveness of these guys are not very high, only 10 to 30%. We can give an injectable medicine called somatostatin, such as octreotide or lanreotide, and you get about a 67% control rate. Again, not anything close to 100%. And these medications have side effects. We have another way to attack hormones that are made in high amounts, and that mechanism is that what we do is we say, okay, let's forget that the hormone is made in high amounts for a second. Let it do what it wants, let it make the extra hormone, and let's come in and give a hormonal blocker. Okay? So rather than giving a medication to lower the hormone, give a medication to block it. And we have such a medication for both Cushing's and acromegaly. In acromegaly, this medication is called pegvisomant. And what happens is that this medicine looks like growth hormone, but it's not growth hormone. It will go and bind to the growth hormone receptor, but block it, so that regular growth hormone can't come and occupy the receptor. And so what we essentially do is we don't let the high growth hormone levels have a negative effect on the individual. And these are called receptor blockers. And when you give a receptor blocker, because you're blocking the receptors, you can get much more efficacy. So these are IGF-1 levels in people who have acromegaly before treatment, which is the dot at the top, and after treatment. And you can see these really, really nice dips of their IGF-1 level into the normal range, which is the white area. And with a receptor blocker for growth hormone, 97% of these people get their disease controlled. So this is an important idea about treating hormonal problems, which is to just give a blocker rather than to give something that inhibits its production. Now, of course, if surgery and medications fail the patient, it's important to say that the treatment failed the patient, not that the patient failed the treatment. This is very important. You know, the treatment fails the patient. The patient does what they can, and we have limited treatments, unfortunately, and one of those is radiation. Radiation will help those people who don't have control with medications and surgery. The problem is that it comes at a relatively high expense, and that expense is that it damages the rest of the pituitary gland and causes pituitary failure, and therefore we would need to give replacements for those hormones that are now deficient. Okay, we're going to talk about Cushing's disease next. Is everybody okay? It's a long presentation. Cushing's disease, well, you can tune out on the areas that are not applicable to you and then tune in when you like. So Cushing's disease is due to an ACTH-producing tumor in the vast majority of cases. Sometimes it can be from an adrenal problem, and sometimes it could be from a ectopic source. Remember, we talked about ectopic sources are sources where, for example, the liver or the lung, which is not supposed to make a hormone, but because there's another tumor, it begins to make it from that particular tumor. Most of these are small tumors. These are the symptoms, and I'll show you pictures. So this is the rounding of the face that has happened. Sometimes it's called a moon face. There's fat deposition over the clavicle. This person with Cushing's disease has developed some body hair, facial hair, because of the high levels of ACTH will stimulate also the release of male hormone from the adrenal glands. And so these are clear-cut, easy to catch features. This is the deposition of fat behind the neck. So hopefully if a person comes to your office and looks like this, you will not miss the diagnosis. The problem is that some of the people with Cushing's disease don't have all of these features that are so clear-cut to see. Now this is a dog with Cushing's. Before Cushing's and after Cushing's, and so according to PetMD, dogs get Cushing's, particularly boxers and poodles and Boston Terriers. And the interesting thing, and the reason I put the slide in here, is that for Cushing's syndrome in dogs, almost exclusively they use medical therapies. They don't use any form of surgery partly because the surgical techniques may not be that great in animals and not as advanced, but because using medications tends to do a good job, and most of these medications work at the level of the adrenals. For example, there's a drug like ketoconazole, which inhibits the production of cortisol from the adrenal glands that are given to animals who have Cushing's disease, particularly dogs. Now, before we treat Cushing's, we need to establish the diagnosis. And sometimes this establishing the diagnosis, establishing that cortisol is made in excess amounts, is incredibly difficult. After we've sufficiently, to our satisfaction, felt that we have proven that there's too much cortisol, then we have to try to figure out where is it coming from. Is it from the pituitary, which happens to be 70% of the time, or is it from some other source like the adrenals or an ectopic source? So we have lots of torture tests to try to determine whether the person has Cushing's or not. We have 24-hour urine tests, we have salivary tests, we have suppression tests. People who've been suspected of Cushing's syndrome know what I'm talking about. And the problem, again, why we have all these different tests is because a single blood test will not capture Cushing's. A number of patients, and one patient whose journey I'll share with you, wanted me to say to everybody and also to the physicians is that sometimes people are dismissed as not having Cushing's syndrome because their blood cortisol level is normal. And, or if it's just mildly above normal and then the diagnosis of Cushing's is excluded. Well, there's no way that you can make any comment on a cortisol level unless it comes back at 0. Any other number could be compatible with normal or abnormal. So these are our torture tests. This is a dog with Cushing's disease or suspected of Cushing's disease, and there's a couple of veterinarians, and it says it's 2 for Cushing's and 2 against, we need another opinion. And again, this is to underscore the challenge that sometimes it's difficult to make that diagnosis, and sometimes when you ask the same question to 2 endocrinologists, you'll get 3 answers. So it's tough, and we have to be patient, and the patient has to be patient until we can get the diagnosis, and then we have a variety of tests to try to figure out where it's coming from. We have additional blood tests. We have, of course, MRI, if there's a tumor in the MRI that could suggest that it's from a pituitary source. The problem is that 50% of the time the MRI is normal in Cushing's disease, so that can help us. And then we have this torture test, which is the petrosa sinus sampling, where a catheter is threaded from the vein in the groin up to the brain, and you take samples of ACTH from the left and from the right, and to determine is it coming from the pituitary first of all, and is it coming from the right or the left. So let me just go through, if it's okay with you, this patient's journey, who gave me permission to discuss her case, and I think, again, it's very instructive. So this is a woman who at the age of 19 began to have acne and hair loss and fatigue, and by 21 she had gained 50 pounds in 3 months. And that happened despite her best efforts to eat well and exercise, which is going to be a common story in many patients with Cushing's syndrome. By age 23, her weight had increased another 80 or more pounds, and now she's 205 pounds, and she's developed hypertension and high cholesterol. And a common feature in Cushing's is cognitive and mood problems, so depression and problems with memory, and essentially this is what patients call brain fog. So here we have 4 years and approximately 14 different physicians that this woman had seen without a diagnosis. She has a cortisol level in the blood of 25, which is reasonably normal for a morning blood draw. Fortunately, in 2002, after a number of years, remember this kind of started in the late 90s for her, she stumbles upon an allergist, of all people, who thinks that maybe she has Cushing's. And why would an allergy think that a person has Cushing's? Well, sometimes allergists give patients steroids to treat asthma. And so when an allergist gives steroids to somebody with really bad asthma, they can get Cushing's, but the Cushing's is from the medication. It's called external Cushing's. And so some doctors, like allergists and asthma doctors and rheumatologists, which can treat conditions with steroids, can be a little bit more suspecting of Cushing's syndrome and try to put things together. The appropriate test is done, and in fact, her 24-hour urinary cortisol, which is a much better test than a regular blood cortisol, is approximately 3 times the upper limits of normal. Her ACTH level is elevated. Many times it's not, but in her case it was elevated. Her MRI was equivocal, which means that it was not clear-cut. It was a possibility of the tumor, and because it was not clear, she had this petrosal sinus sampling procedure done to try to figure out where the source was. So this is the patient pre-Cushing's and how she developed afterwards. A significant amount of weight changes in the characteristic distribution where I mentioned. In 2002, she has surgery, and as expected from a successful surgery, her cortisol levels go down very low. And in fact, they go below normal. And for a period of time, she needs to be on actual cortisol replacement, in this case, hydrocortisone. In her case, the period that it took for her pituitary adrenal axis to recover was very prolonged. Usually this period of time is about 6 months to a year. In her case, it took, you can do the math, like 4 to 5 years for her to get recovery of her adrenal axis so she can then stop taking cortisol replacement. This is a very difficult time because cortisol levels going from high to being very low could cause lots of withdrawal symptoms, and she felt very poorly. But the nice thing was that her weight went back down to 118 pounds to her baseline. She did develop low IGF-1 and hypothyroidism. Fortunately, her menstrual cycles were normal, and this is her back to her pre-Cushing's appearance. And so this is very satisfying, but unfortunately, this is a bad disease. A couple of years later, her weight goes back up to 157 pounds. Her urinary free cortisol is 64, and so, her doctor's thinking, okay, maybe this is not so bad, but obviously it's abnormal, and so we are, in somebody who's gaining weight again and has this, there's no question that this condition is now coming back. 2 years later, her weight goes back to the 202 pounds, and now again, her urinary free cortisol is clearly out of the range. Her ACTH is high again, and here we go again, MRI, possible area. But we know that in this case it was in the pituitary, so probably it's going to be in the pituitary again. So now what do we tell this person? What are her options? What do we do for somebody who has Cushing's disease, who has seemingly successful surgery, and now the disease has recurred? This is a tough problem. But it's not an uncommon problem. If you look at the statistics at good centers, these are centers with surgeons that are extremely qualified at doing pituitary surgery. This is a series from Dr. Edward Laws, who's probably, he's done more pituitary surgeries than anybody else alive. And so this is the best case possibility, and it suggests that after 5 years, about 25% of patients with Cushing's disease recur. So you can't pat yourself on the back too much. You have to continue to be vigilant and monitor because this condition has a tendency to recur. So this is back to her numbers. And so these are the treatment options she has now. The first option is, well, surgery worked good the first time. Will it work again? The other possibility is radiation. Another possibility is adrenalectomy, none of which are particularly palatable. to the patient or to the doctor. Radiosurgery we talked about can wipe out the normal gland. Bilateral adrenalectomy now converts this condition to Addison's disease, essentially, and now the person is steroid dependent for the rest of their life. And fortunately, we have two medications now that have been approved over the last couple of years to treat Cushing's disease that is recurrent or in those patients who are felt not to be surgical candidates. And these are what we're going to talk about for a few minutes and then end the presentation. So this is mifepristone and pasireotide. Keep in mind that there's a bunch of medicines that we've been using for the last 30, 40 years, but those are off-label, meaning that they have not been approved by the FDA to treat Cushing's disease, although we use them extensively. And this is ketoconazole, which is sort of like this analog of the medication that we treated that little doggy who had Cushing's disease. We have carbergoline, the same one that we use to treat pituitary prolactinomas, and the same one we use potentially to treat some of the acromegalics. And then we have some nasty things like mitotane, which actually causes a destruction of the adrenal gland. We usually give this to people who have adrenal cancer. And we have intravenous medications, etomidate, which is an anesthetic drug, which in addition to putting you, sort of into a sedated state, will lower the cortisol levels. Obviously, you can't be hooked up to an IV medication for the rest of your life. So these are sometimes used, like etomidate is used in the intensive care unit when somebody has really high cortisol levels and you want to bring them down fast. And the rest we have some experience with, but not long-term good studies. This patient chose to have a second surgery. This slide that I went through really quickly actually is a slide also from Dr. Law's surgical experience, which says that if a person who has an initial surgery with Cushing's disease and then the disease recurs, and they then have the option to repeat their surgery and they take that option, how likely is the second surgery to then put them into remission again? So what is the success rate of a repeat surgery for Cushing's disease? Again, keep in mind that this is in the best of the cases, and the bottom line is that statistic goes down to about 50%. So whereas the initial surgery for a microadenoma causing Cushing's disease can be as high as 80 to 90%, when we go back a second time, when the surgeon goes back a second time, the odds are much lower. And it can come at significant risk. Some of these patients end up having pituitary failure. And the reason that they end up having pituitary failure is that sometimes their second surgery ends up removing normal pituitary tissue because they can't really, the surgeon can't really localize where the tumor is. So for example, may take half of the pituitary gland or a quarter of the pituitary gland. This patient decided to have surgery, and the good news was that after her second surgery, the cortisol levels nicely declined again. She was put on cortisol replacement again because her cortisol was 0 after the successful surgery. This time, her adrenal axis recovered very quickly. Now, initially it took her several years for the adrenal axis to come back, so she was on cortisone for a couple of years. This time it was only a couple of months, which is a bad sign as well. And the reason is that when the cortisol axis recovers so fast after Cushing's disease, it usually means that it's going to recur. So the hydrocortisone was stopped. This time she didn't have much of an improvement in her weight. Although the cortisol level did go down, it was very short-lived, and her weight only went down to 193 pounds. And again, by December of 2013, we have an elevation in her urinary free cortisol. This time it's only 5 points above normal. Again, the point of this patient is that 5 points, 1 point, 2 points doesn't necessarily correlate with the fact that she's still 80 pounds above her weight that it should be pre-Cushing's. So now what do we do? So we go back to our slide. We can do some of these medical treatments, and because we have 2 approved FDA-approved treatments, in her case, we decided to try mifepristone. And mifepristone is a progesterone blocker, but it also blocks cortisol. So sort of like the slide that I showed you in those people who have acromegaly and you let their growth hormones stay high, but you block its action, this is the same idea with mifepristone. So you're giving a drug that will block the high cortisol level and not let it cause damage or problems to the body. Let me just, because we're running out of time, cut to the chase in that in this study, there was a response rate of approximately 60%, meaning that based on the criteria that this study had, which is improvement in their blood sugars and Cushing's features, there was a 60% response rate in terms of blood sugars, a 38% response in terms of blood pressure. The other important effect is weight reduction and body fat reduction as depicted here. I'm going to just go through these quickly. So this is again showing the fat and the weight, body weight coming down. Body fat is going down much more, so in fact you're increasing lean body mass with this medication. Of course, it has side effects. No medication is without side effects. These are the side effects of mifepristone. Many of these side effects are actually because the cortisol level is dropping, and the cortisol withdrawal symptoms like nausea, fatigue, body aches, and so on and so forth. The other medication that is available in case, that's FDA approved in case mifepristone does not work for the patient, or in case you can just start with this medication as well, it's also approved for Cushing's disease, and this targets the tumor itself. It works at the level of the pituitary tumor and prevents the formation of ACTH, or reduces the formation of ACTH and therefore cortisol levels. In this study, let's just look at this slide. Let me go to the end. So the very end, the response rate to this in terms of normalizing the cortisol level, if you use the 0.6 milligram dose, was 15%, and the 0.9 milligram dose, 26%. So this is the overall response to pasireotide in terms of normalizing the urinary free cortisol. It turns out with this medication, pasireotide, if you break down the people who responded versus those who didn't, those people who had relatively mild elevations in their urinary free cortisol, only 1.5 to 2-fold above normal, had about a 50% response rate. So although the overall response rate is fairly low, if you give this medication to people who have relatively milder elevations in their urinary free cortisol, you can get a better response rate. And remember, I mentioned before that having milder elevation in cortisol level doesn't necessarily mean that their Cushing's is milder clinically. So this is pasireotide. Of course, this medication has adverse side effects as well. It's listed here. A lot of them are gastrointestinal. Of course, pasireotide is an injectable medication. A once-a-month long-acting form is being studied right now, and it's not yet FDA approved for Cushing's disease, but will probably be available shortly. So for the patient we started her on, that we're talking about, on mifepristone at 300 milligrams a day, and really we had to bump up the dose because at 1 tablet a day she had really no response, and at 1,500 milligrams she finally is starting to have some weight reduction, 20-pound weight loss, but many of her symptoms are still present, and we're hopeful that they will get better as time goes by. She's developed amenorrhea, which means that her menstrual cycles have stopped. This sometimes can happen. Sometimes you can get increased vaginal bleeding with mifepristone. Remember, mifepristone is a progesterone blocker. It's really the same medication as RU486, which is the abortion medication. So you are blocking progesterone, and so menstrual irregularities can happen. Do we have more time, or is the next speaker ready? Let's stop and ask questions, and then I can be available if there's other questions at the end. So I gave you an overview of pituitary problems and some of the more important pituitary tumors. And let's just take some questions. I'll leave the non-functioning slide here so whoever wants to read it can read it. The cabergoline is a medicine that binds to dopamine receptors. It also binds to a subtype of serotonin receptors which are found on the valves of the heart. And so there is some concern that high doses of cabergoline or if low doses of carbergoline are given for a long time, it could damage the valves of the heart. Now, that comes from studies where carbergoline was given at really high doses. For example, 20 times the dose that we would give to a prolactin patient. But nevertheless, it still makes us a little bit worried that if carbergoline is used at doses greater than about 4 to 6 tablets a week, which is roughly 3 milligrams per week, each tablet is 0.5 milligrams, that at doses above that, if given for a long time, could have negative effects on the heart valve. So at people who are going to be on carbergoline for a long time, which is usually how long we have to treat them, there could be a concern at high doses for heart valve problems, and that would need to be monitored. Now, there are times that we give people drug holidays from these medications. So as I said, the pituitary tumor will shrink when you give them carbergoline, and the prolactin will become normal. And sometimes, if you've shrunken the tumor so well that you can't see it on the MRI anymore, let's say you've done that for 4 or 5 years, it would be wise to give a holiday from the drug. And it could be that for a year or two, and sometimes I've had patients longer, 3 or 4 years, they can go without the medication and continue to have normal prolactin levels and non-growth of their, or regrowth of their tumor.